Hello, and welcome to Empiric Antibiotic Therapy by Disease State. My name is Robert Lasco. I'm a clinical pharmacist in the Washington Hospital Emergency Department, and I'm also the founder of MedMinded Consulting. We can take care of any of your graphic design, media, web design needs. So let's just get right into it. The first disease state to go over is community-acquired pneumonia. The definition is pretty self-explanatory, so it's pneumonia from a community setting. We're not going to get too much into specific pathogens just because it doesn't really change the course of treatment. So there are two different approaches you can use. There is the two-agent approach. So you pick one beta-lactam, so something like Augmentin, Unison, ceftriaxone, or cefuroxime, and then you add to it either a macrolide like azithromycin or doxycycline. So the beta-lactam will take care of your staph and strep species, and then the macrolide or doxy takes care of atypical organisms. Or you could do monotherapy with respiratory fluoroquinolones, such as levofloxacin. That will cover staph, strep, and your atypicals, so the most common pathogens for CAP. Next up is hospital-acquired pneumonia. First and foremost, healthcare-associated pneumonia does not exist anymore. Just because someone is from a skilled nursing facility or some sort of rehab center doesn't mean you need to cover for HAP. For example, if I were to get sick, I work 8 hours pretty much every single day in a hospital. You don't need to cover me for HAP just because I get pneumonia. I have to have, other risk factors for a multi-drug resistant infection. So HAP is in a patient who develops pneumonia greater than 48 hours after admission. You also might want to cover for HAP organisms if they've received IV antibiotics within the past 90 days. So principles of covering for HAP, you need to cover for two organisms. The first one is Pseudomonas aeruginosa. So that'll be stuff like pip/tazo or zosyn or cefepime, which I personally prefer to other things like ciprofloxacin, ceftazidime, aztreonam, and aminoglycosides. Mainly because our minimum inhibitory concentrations have gone up for things like ceftazidime and ciprofloxacin, especially aztreonam, and aminoglycosides are a bit of a pain in the butt to dose, and they also require frequent monitoring, whereas our MICs for things like zosyn and cefepime are much more manageable. They're not creeping up, and they're also less toxic to various body systems. So in addition to Pseudomonas, you also have to cover for MRSA. So that would be stuff like vancomycin, which I would probably just stick with Vanco, but you can also use linezolid or telavancin. Telavancin, of course, being sort of like a longer-acting, more refined derivative of vancomycin. So next up, we have ventilator-associated pneumonia. It's a type of hospital-acquired pneumonia, but it's occurring greater than 48 hours after endotracheal intubation. So treatment is based on the multi-drug resistant risk stratification. So if you have a patient that's at low risk for multi-drug resistant organisms, you could treat with monotherapy with something like zosyn, cefepime, or levofloxacin, something that covers those gram-negative organisms. But if they're at a high risk for MDR organisms, you might want to move towards a possible 3-drug regimen. So the first one you want to cover for Pseudomonas. So you would use zosyn, cefepime, ceftazidime, or carbapenem, depending on who the patient is. And then on top of that, you could add an aminoglycoside or an anti-pseudomonofluoroquinolone like ciprofloxacin. But if you can't add either of those, you might want to consider adding aztreonam or rarely a polymyxin derivative, depending on how multi-drug resistant we're thinking they're going to become. And then lastly, you want to add MRSA coverage with Vanco, telavancin, or linezolid. And as expected, you want to individualize your treatment approach to your institution's antibiogram just to see what would be most susceptible. So the next disease state to go over is aspiration pneumonia. Whenever people ask me what they should use to cover for aspiration pneumonia, the first thing I like to ask is it aspiration pneumonia where you need antibiotics, or is it aspiration pneumonitis where there's not a bacterial infection and supportive care is mainstay of therapy? So unnecessary antibiotics lead to an increased risk of drug-resistant infections and C. diff, all kinds of bad stuff. nephrotoxicity, possibly neurotoxicity, ototoxicity. The list goes on. So you need to determine the probability of drug-resistant infections for aspiration pneumonia. So kind of stratifying again, have they received IV antibiotics in the past 90 days? Do they have a history of drug-resistant infections? So if either of those answers are yes, you would want to treat with a hospital-acquired regimen. Otherwise, you could treat for a CAP regimen, but generally they prefer Augmentin or Unison just because those two antibiotics will cover anaerobes. So next up, intra-abdominal infections. So the principles for covering for intra-abdominal infections, you want to cover for gram-negative anaerobes. So there's a 2-drug regimen where you could pick either ciprofloxacin or ceftriaxone. That covers your gram-negative organism. And then whichever one of those you pick, just add metronidazole, which will cover your anaerobes. So if they have a cipro allergy, use ceftriaxone and vice versa. Or you could just use monotherapy with one drug. It really depends on severity, which one you want to choose. So you could lean towards Zosyn or Unison, Augmentin, even Bactrim. Those all cover gram-negatives and anaerobes. I tend to reserve Zosyn more for like cholecystitis or, a ruptured appendicitis, perforated viscus, stuff like that, some more serious infections that can lead to sepsis. Whereas my Amsulbactam and Amoxiclav, even the Bactrim, could reserve for, an acute, uncomplicated diverticulitis. So notable exceptions to these rules, peritonitis. So this is commonly seen more so in patients with liver issues, collecting a lot of fluid, like with ascites. So for prevention of peritonitis, especially SBP, spontaneous bacterial peritonitis, 1 gram of ceftriaxone once a day is for prevention, 2 grams of ceftriaxone once a day is for treatment, or you could use Cipro plus Flagyl if the patient has a severe cephalosporin allergy. But I would almost lean entirely on ceftriaxone unless they have a proven allergy to ceftriaxone or something with a similar R1 side chain. Next up, skin and soft tissue infections. So typically in these infections, you want to cover for staph and strep. There's 2 different categories to treat with SSTIs. So you have your MSSA or your MRSA, so methicillin susceptible or methicillin resistant. So with MSSA, it's just typically cellulitis, your run-of-the-mill redness, no purulence, just redness, no abscesses. So for stuff like that, you could just use Keflex or Ancef, or you could also use, oxacillin or dicloxacillin, but usually the first-generation cephalosporins are the things that I would reach for. And then once you start getting into MRSA, they become more purulent. You might see an abscess. IV drug use, it provides a much greater risk of MRSA infection. Also a history of MRSA, systemic symptoms like fever, tachycardia starting to hit criteria for sepsis. Antibiotics that cover for MRSA. So Doxy and Bactrim are great if you're going to send this patient home and not be admitted to the hospital. They have excellent MRSA coverage, at least on our antibiogram, they're greater than 90%. Whereas something like a PO Clinda, even IV Clinda, it would be the same. We're running about 73% susceptibility, so we have a higher failure rate with clindamycin, at least in my area. But if you're going to admit them to the hospital, you could also just use our workhorse vancomycin. So next up is osteomyelitis. So whenever somebody asks me what they should use to treat osteomyelitis, I always ask them, are they stable or are they septic? So why is this important? So if they're stable and not septic, I usually encourage no antibiotics in the emergency department, at least until, some sort of consult to podiatry or ortho or whoever is going to take them to the operating room. So it preserves the susceptibility of the bacteria for an operating room culture, for if they debride or amputate bones. Because once you get osteomyelitis, usually that bone is toast, so it's going to come out anyways. Now, it changes a little bit if they're unstable or septic. So in that case, we employ broad coverage for gram-negatives and MRSA. So 2 drug regimens. The first is a 3rd or a 4th generation cephalosporin. So ceftriaxone is your 3rd gen, cefepime is your 4th gen. Diabetic feet with wounds on the bottom of their feet, I would usually lean more towards cefepime because Pseudomonas tends to grow on the bottom of diabetic feet. I don't know why. And then also you want to add vancomycin to cover for MRSA. So, and then once you get the OR cultures back, you always want to switch to pathogen-directed therapy. Half of these patients are going to be discharged on something like cefazolin for several weeks. So, yeah. Next up is UTI cystitis. So this is simple cystitis. Duration of therapy is 3 to 5 days. You can really get away with 3. There's a bunch of different antibiotic choices, especially for your patients with multiple drug allergies. So Keflex, Macrobid, Augmentin, Bactrim, fluoroquinolones. These infections do not involve the upper urinary tract or the kidneys. There are no systemic symptoms. And then if you're thinking about using fosfomycin, I would tend to reserve that for people with MDR infections or risk factors. Next up is UTI pyelonephritis. So now the UTI is involving the kidney. These infections have a duration of therapy of 10 to 14 days. So if you're going to send this patient home, I tend to reach more for the third generation cephalosporins. So give them a dose, 1 gram of Rocephin in the emergency department, and then send them home on a PO regimen of either ceftonir or cefpodoxime. Alternatively, you could use ciprofloxacin, but you might want to refer to your institution's antibiogram because they don't recommend fluoroquinolones if resistance with multiple bacteria is greater than 20%. So that's why we like to use the third-gen cephalosporins. If they're going to be kept inpatient, IV therapy with Cipro or ceftriaxone is appropriate. Right now, it's currently March 26th of 2023. It's impossible for us to get 400 milligram IV ciprofloxacin for some reason, so pretty much everybody's getting ceftriaxone. And then if they're septic, you want to do an anti-pseudomonal plus MRSA coverage and then de-escalate with your culture and susceptibility. So basically want to cover them for sepsis. And always just refer to your institutional antibiogram. So last but certainly not least is meningitis. So it's life-threatening. Really avoid delay once it's recognized or suspected. So there's a bunch of different aspects of coverage. Some are for everybody and some are just for some people. So there is a stepwise approach that I kind of laid out here in order of, like if you qualify for 1, look at 2. But if you don't qualify for 2, you probably don't need 3, stuff like that. So rule 1, everybody gets ceftriaxone 2 grams Q12 hours. This is the only indication for ceftriaxone 2 grams every 12 that I can think of. So everyone gets 2 grams of Rocephin every 12 hours. It has great CNS penetration, especially with inflammation. And then everybody gets vancomycin, without exception. Vanco penetrates the CNS and crosses the blood-brain barrier with heavy inflammation. Otherwise, it's not as reliable. So if they do have meningitis, it's very good at penetrating the infected tissue. So everyone gets Rocephin, everyone gets vancomycin. So if you get an LP and it's not really showing much for bacterial infection, but let's say you're concerned for viral, add acyclovir. I would say it's not going to hurt, but it could cause renal dysfunction. But just make sure you dose that 10 milligrams per kilo for their ideal body weight, not actual body weight. It's ideal, okay? And then after that, if they're immunocompromised, you might want to substitute ceftriaxone from meropenem just to cover for even more multi-drug resistant organisms. And also if they're over 50, you need to cover listeria with ampicillin. But if you're already immunocompromised and on meropenem, you don't have to add ampicillin, mainly because meropenem will already cover listeria. So, and then if they are on Rocephin and they are over 50, it's okay to add ampicillin. I know it's 2 beta-lactams, but it's like one of the instances where you can do it. All right, well, that's about it. It should get you about 90% of what you need to know. If you're a pharmacy student, it's about 90% of what you need to know for the NAPLEX. So this is just the essential rundown on some of the most common infectious disease states that I see with, some pretty great treatment options. So study guides like this really help me get through my test. So hopefully it gets you through yours. And feel free to email any questions to that email address or comment questions or feedback below. Thanks so much and see you guys next time.